Thank you very much. So kidney sparing surgery is a real concern in upper tract tumor because we have to be honest, in the vast majority of cases, we have been doing radical nephrorectomy for years. It is still the gold standard, but there are more and more cases that are likely to be suitable for kidney preservation. And I would like to deal with the criteria that we have established and that are likely to move because it's a dynamic process. These are my conflict of interest, and I agree with the statement which was done yesterday saying that an expert without conflict is an expert without interest. So urothelial carcinoma is a whole entity, and actually the session is perfectly delineated because it's not only bladder cancer, which is a reservoir, and the vast majority of the cases are in the lower tract, but it comes together with what's going on in the upper urinary tract. And we have touched on the point of the epidemiology of the disease, which has nothing to do in Asia, especially in Taiwan, with what we have in Europe, because the incidence is quite low in Europe. I would say the whole amount of urothelial cancer, it's only 5% of cases at max. But anyway, the urothelial carcinoma, there is an initiation process. Most of the time, we all know about the tobacco consumption, which is a problem. The initiation and the promotion. When it comes to bulky or exophytic tumor, there is also the CIS phenomenon, which is not really depicted in the upper tract, and there is no reason why there should be no CIS in the upper tract. And the thing is the muscle layer. So you know the stratification that we have, non-muscle invasive bladder cancer. We have the leader of the guidelines, muscle invasive bladder cancer as well. But there is no non-muscle or muscle invasive upper tract for the simple reason that it is more or less a situation like facing a tumor in the bladder diverticula. So when it comes to upper tract, it's localized or locally advanced or metastatic. But as a urologist, you do not want to become only an endourologist because it's not only being good at tips and tricks and how to do a ureteroscopy, because you will control the disease on the endocavitary side. But there is the bladder wall or the urothelial wall phenomenon, and what we miss probably is the micrometastatic phenomenon. So we don't know if it's an understatement or an overtreatment or when we face an upper tract tumor. For sure, for many years, we took out too many kidneys. And there is a proportion of patients or tumors that are likely to be treated with the preservation of the kidney. But we have to be cautious because it can be a very dangerous disease. So the question there, the only question which we can have from this presentation is, do we do a suboptimal treatment versus over-treatment when it comes to take out the kidney, and not only the kidney, the upper urinary tract, and the bladder cuff? So we have guidelines. This is the last version of the guidelines which has been released in European Urology, how to offer kidney sparing strategy to the appropriate patient. I think it's a question of stratification, allocation, and we are aware of the stratification that we do in non-muscle invasive bladder cancer, low risk, intermediate, high risk, super high risk. There is an accurate risk stratification which is possible also in the upper tract. The challenge is to select those patients with low-grade, low-stage disease eligible for endoscopic therapy. Look at the picture on the top corner on the right. It can appear at a very simple, easy disease to overcome, but it can be very tricky. And there are two situations, two distinct situations, a patient with two functional kidneys and a patient with a solitary kidney, which makes it totally different. Because in a solitary kidney, you will push back the limits of conservative management as much as you can. There is a balance between the risk of being under dialysis and the oncological outcome. But the expectancy of life of a patient diagnosed with a cancer who is under dialysis is extremely low. So you need to preserve as much as you can. When you have two kidneys, the situation is different, and this applies. This is a flow chart which is based on clinical criteria, pathological criteria. Some people are discussing the cutoff of 2 centimeters, of course. When you are very skilled, seasoned experts of endourology, you say it's not too much. But do not forget that the guidelines is at least the minimum you could do. If you are very skilled, then the cherry on the cake is what you do. But you need to bring back your experience to the literature so we can incorporate it in the guidelines and keep moving forward in the evolution. we have guidelines that are saying that according to the location within the upper tract and according to, I would say, the low risk or high risk stratification, you can even consider conservative management. We had this systematic review when James Endo was appointed as chair of the guidelines before Maria Ribari said we need to trigger some PICO. So one of the first PICO we had in the panel was to compare the kidney sparing strategy versus radical nephrectomy. And if you look at the conclusion, it's saying that in low-grade, non-invasive upper tract, the outcome is similar. So do not be, I would say, afraid to preserve. Endoscopic management is the first thing that we are considering when it comes to kidney strategy, kidney preservation strategy. You need to have a nice vision, and you have many booths here with many manufacturers bringing up new tools. What is the best? It comes with an investment in the quality of the vision. It has nothing to do with the last version and the last vision that is provided by the new generation of ureteroscope than we had before. So of course, when you come to a congress, you say, it's wonderful, I have a superb images, and when you go back to your eye, it's totally blurred, it's bleeding everywhere, you cannot see anything. So it is true also that we have complication, difficulties when it comes to ureteroscopy. The thing is that you are not treating stones, you are treating tumor. So what you want to see is the wall, ureteral wall. You need to have a full observation of what's going on there because the MRI at the moment or the CT is far from being perfect. So it's very important. As much as you can to have and to depict the whole vision. The biopsy is certainly a good way to assess the grades. Unfortunately, in many cases, very difficult to assess the stage. There are new tools that are under development, such as Cellvigio or Histolog, that could help you in the near future to assess the invasion. For the moment, it's too premature to state. There is no, I would say, frozen section, and the problem is that when you are seeing a patient there, you are seeing the tumor, you can do the biopsy, but you don't have the outcome of the biopsy. So do you wake the patient up? Do you reschedule the patient in the OR to treat him because you are supposed to treat only low grade? It's difficult. So most of the time you are treating patient based on a subjective decision. So I can deal with it, I can treat it, but you don't know what you are treating. So maybe you are spending a lot of time to treat a high-grade tumor. The technique also has an influence on the way you treat the patient and you potentially disseminate the tumor, but because there is an increased risk of bladder recurrence after flexible ureteroscopy, and it's a major concern. We all know that the guidelines is advocating the possibility to deliver chemotherapy after radical nephroureterectomy in the bladder. It's not really done because people are afraid of the bladder scar and extravasation of chemotherapy. The question that arises behind is, do we need to do instillation after flexible ureteroscopy? And no one has the answer at the moment because it's very difficult to trigger the trial, and it was something that we proposed to the Research Foundation at the moment, but there is no grant and nothing to help us. So real-time diagnosis is the quick question. We had in the 80s, I mean in France, I don't know how it goes in Hong Kong, but we could bring a pathologist to the OR. There is no more pathologists. I don't know where they are drinking coffee. But there is not a single pathologist who is available for frozen section analysis. So at the moment, you need to be on your own. So the best manner is to get rid of them and to use artificial intelligence, to use any new tools that is available likely to replace them. They don't realize, but they will be replaced. But they don't care because they will drink coffee. So the Cellvigio system is very interesting. It's a system which is already validated in gastroenterology for, I would say, linear cancer. It is used in some, I would say, on a very preliminary steps, and I discussed with Alberto Breda, the Puig-Vert Foundation in Barcelona. He has been using it in a few patients. As you can see, there was a good correlation in high-grade tumor between what was seen perioperatively and what was discovered on the histological assessment. Do not forget that conservative management is not only endoscopy, not only flexible ureteroscopy. Segmental ureterectomy is an excellent treatment of distal tumor, especially in aging patients. And on top of that, what you could consider with a segmental ureterectomy is the possibility to do in lymphadenectomy. I don't know any skilled ureteroscopist that can do a lymphadenectomy with his ureteroscope at the same time. You can do that at the time of segmental ureterectomy, which can be done old-fashioned open surgery, but which can be done robotically. And we have an experience with that in Paris. We are super happy with the patient that we treated like that. This is the position of the patient. And this is typically what we try to do if the movie, well, I don't know if it's going on. Ah, yes. So at the beginning, we use the firefly to dissect the tumor. You can see the ureter in yellow, the artery in red. But actually, it's quite simple. And we were discussing at the breakfast with Paolo Gontero. We had it in the room because we share the room. No, I'm kidding. And so he's using the single port now and starting his experience with a single port. I don't have this experience because we have the XI. But what is nice, this is the firefly use, but honestly, it's a gadget. We don't use it anymore. It's just for the Congress. It appears that the single port is very helpful to rotate from the, I would say, kidney level to the distal ureter. So it's even easier. So segmental ureterectomy belongs to the kidney sparing strategy, and it's absolutely important. The question behind is, do we do instillation after conservative management? How do we do instillation in the upper tract? Because in many conferences, they tell you, you should do instillation, and nobody is doing it. Actually, very subjectively, you would say, okay, I put a double G stent, I put a bladder catheter, and it's done. I put the chemo or the BCG within the bladder, and the reflux will do the job. If you have done some stones, or if you have done some opacification of the upper tract and use the X-ray after 5 seconds, you will see the dilution, and you will understand it will not work. Then there is the possibility of the single G stent or the antegrad and percutaneous. If you look at all these draws, it seems to be perfect on the paper. The reality is that you need to find a balance between safety, treatment efficacy, and patient friendliness. In terms of retrograde with double G stents, honestly, it's totally disqualified. Doesn't work. In fact, it's just to publish a paper, one more in the literature, to say nothing. The retrograde with single G stent, it's not working old-fashioned as well. No control of the outflow, adverse to properties, unknown intrapialic pressure. There are many problems. It's extremely dangerous potentially. So you don't know what you are doing, in fact. And the only thing which is potentially working is that, but honestly, it's not really patient-friendly. Percutaneous nephrostomy tube with a continuous flow for 2 hours. It can be considered in dead-end situations, but at the moment, in fact, the only thing that could be considered seriously is the percutaneous administration of BCG. What about the follow-up? It's much more eminence-based than evidence-based. People are discussing, they're saying, oh, we should do that, we should do that. There is no evidence, but everybody's happy. So the follow-up is that we go more and more into a stringent surveillance for people who have lesion and multiple location. So what we are looking at is the possibility to do what we call a second look, as we do it in T1 high-grade tumor. But we need a good compliance from the patient's side, and they need to understand the situation. Otherwise, it's going to be complicated. So what does the future hold? As I told you, remaining questions are, do we need intravesical single-dose chemotherapy in the bladder after kidney-sparing strategy? Probably yes, but it's too premature to state, and there is not a single company that is affording the cost of such a trial, because we need a huge number of centers in Europe to resolve the question. Maybe 2 centers in Taiwan, and it will be done. But nobody is paying for the cost of the trial. And there are new kids on the block that are interesting potentially in the upper tract, specifically in the upper tract. Professor Gontero will touch on the new generation of treatment for non-muscle invasive bladder cancer. Could be the same, but the technical difficulties to reach the upper tract can be tricky. So there is the GEL-MITO trial, which is mitomycin, which has nothing new there. Mitomycin is not treating CIS. Mitomycin is chemotherapy as we know it, but the particularities there that is you have the gel, which is likely to give you a better adherence to the surface and to the urothelial wall. So there was two, I would say, publications released around it. One in the Lancet Oncology. It's very rare, I would say, to have single arm phase 3 trial. It's only in the United States that you can see that. It will never get accepted in Europe with the EMEA to have a single arm phase 3 trial. I don't know. I don't know if you can qualify a single arm phase 3, but apparently they can do it. It's written in the title. As you can see, one patient out of two had, I would say, a control, which was likely to be achieved with the gel. So it's interesting. We should follow up on that. There was even the UTUC, which has been used in the prostate with some publication which were done back in 2013, which is likely to be used in the upper tract. They try to open our center in Paris, but they step back and then they come back, and we don't know if it's a financial issue or a technical issue or a scientific issue, but there is a rationale behind it. It could be interesting. And the last thing is nadofaragine firadenovec, which is a gene therapy. Maybe Paulo Gontero will develop on that. The problem is that at the moment, nadofaragine firadenovec has been approved in refractory patient, I think, by the FDA in non-muscle invasive bladder cancer. The idea is to develop a trial in low-grade, a marker lesion trial, to do some chemoablation with a de-escalation dose. So we opened the trial in Paris, and we will be recruiting the first patient early 2025. You can see the trial on the top corner on the right. It's called LUNAR, low-grade upper tract nadofaragine firadenovec administration to the renal pelvis. So ultimately, if you do the restratification as it is done, based on the therapeutic option, no, it's ringing, then the dinner is ready. And the therapeutic option, then you have the low risk and the intermediate risk based on the options that you would propose after. So the take-home message is, of course, radical nephrorectomy remain the gold standard, but kidney-preserving management should be considered in more and more patients. I consider that 1/3 of the patients are suitable for kidney preservation. Thank you very much.